The FAME-2 study has created a lot of interest recently since it was halted prematurely early this year, and now it's reported in the New England Journal of Medicine. FAME-2 randomized stable angina patients who had FFRs less than 0.8 across a coronary lesion to either PCI and optimal medical therapy or optimal medical therapy alone. The study was halted prematurely because of a significant difference in the percentage of patients who had a primary endpoint event, 4% in the PCI group and 13% in the medical therapy group. The difference was driven by a lower rate of urgent revascularization in the PCI group compared to the medical therapy group. Importantly, in the PCI group, fewer urgent revascularizations were triggered by a myocardial infarction or evidence of ischemia on ECG. So what is the take-home message from the FAME studies? FAME-1 showed us that FFR-guided PCI had better outcomes than angiographically guided PCI, and that angiographically guided PCI had more upfront complications than medical therapy because of stenting, of course. FAME-2 indicates that in patients with stable coronary artery disease and functionally significant stenoses, FFR-guided PCI plus the best available medical therapy as compared with the best available medical therapy alone decreased the need for urgent revascularization. It seems to boil down to whether patients have ischemia or not. Patients with ischemia and FFRs less than 0.8 do better with stenting. But these studies underline that not all patients with borderline stenoses should have stents. In patients without ischemia, the outcome appears to be favorable with best available medical therapy. I suspect that these results will have far-reaching implications. Oversight committees will take notice of these studies, and we will all be held to document evidence of ischemia in our patients by stress testing or ECG changes or positive enzyme studies or FFR before we move to stenting. I'm Peter Block, and this is a CardioSource Heart Minute.